Welcome to Sex Ed with DB. I'm your host, DB. Let's get into it. I'm Jamie.
And I'm Rachel.
And we're in debt.
We are in debt.
Because
we're deadbeats.
Losers.
We care more about dancing than making money.
Actually, we've struggled with money because
most people do.
I never thought anybody was in credit card debt like me.
And that's what this podcast is all about.
The first season of Deadheads explores the insidious political and economic policies.
Do you know what your interest rate is?
As well as the seismic but elusive cultural shift.
You know, I'll buy like a tote bag and go, why the hell do I need another tote bag?
That have defined America over the last 4 decades.
Just being alive is expensive. I'm getting priced out of living in America.
Deadheads will make you laugh till you cry.
Or cry until you laugh.
And it's out now wherever you get your podcasts.
Let's talk about solo sex. Masturbation can help reduce stress, improve sleep, and help you figure out what actually feels good for you. One of my go-tos when I'm having me time is Uber Lube. It's super smooth, it lasts a long time, and it helps every touch feel better, truly. It's also latex compatible, so it's great with condoms, and it even helps reduce chafing for workouts or thigh rub season. Also, here's a very fun fact. Stylists use it as a hair serum flyaway tamer. Pretty cool. Uber Lube is a real multitasker. If you're curious and haven't tried it, you should try it for yourself. Use code SEXEDWITHDB for 10% off at uberlube.com and see why Uber Lube is my all-time fave. Hello. Welcome back to Sex Ed with DB. I'm DB, your favorite sex educator and pleasure expert. And today we're talking all about a very misunderstood hormone, testosterone. I am joined this week by my amazing mom, Dr. Rebecca Levy-Gantt. Longtime listeners of this show have definitely heard from her before, but if this is your first time hearing her in an episode, she's not just my mom. She's also a recently retired and very successful obstetrician gynecologist who has worked with women of all ages for over 30 years now. And that's vital because today we're talking about a piece from the New York Times that's been making the rounds online and in communities where people are talking about healthcare and talking about hormones. On October 22nd, 2025, the New York Times published a piece titled, "I'm on Fire. Testosterone is giving women back their sex drive, and then some." And it's written by Susan Dominus, who's been writing for the publication for over 10 years. Her work often talks about women in power, women's health, and women's rights. And we will link the piece in the show notes for you to check out before this episode, ideally, but if not, definitely after. In this article, Dominus interviews women who have been combating menopause symptoms with testosterone prescriptions. Some women are getting prescriptions suggested by their medical care team, but some are hearing about the benefits of testosterone through social media, like TikTok or Facebook. So, what actually is testosterone? What does it do? How does it work? And why are cis men the only people with actual easy access to it if it's so helpful for more than just cis men? One last note before we dive in, and we touch on this during our conversation, but this article does not focus on trans people of any kind. Trans men are only mentioned twice in passing, and non-binary people and trans women are completely left out of the discussion about hormones. While usually this wouldn't feel too suspect, the New York Times has come under fire consistently for its regressive, harmful coverage and misinformation about trans people. We will share some links about this in the description so you can learn more if you're interested. But for now, let's get into this conversation with my mom, Dr. Rebecca Levy-Gantt. Hello, Mom. Welcome to the show. How are you?
I'm good. How are you, Dan?
I'm great. Thrilled to have you on today, as always. We've had you on many times to talk about all sorts of things. I feel like you're the guest with the most downloads on the show. You must be, because you've been on so many times. All about pregnancy 101 and stuff around vagina lasers and making the vagina feel better and hyposexuality disorder and hypersexuality disorder. We've really run the gamut over the past 8.5 years that you've been on the show. And today we're going to be talking all about a New York Times article called "I'm on Fire. Testosterone is giving women back their sex drive and then some." And, this article has really been sweeping the internet. And a lot of people have been talking about testosterone for women over the past few months. And you've been a doctor, now retired, but for over 30 years. And I'm sure you have lots of different stories all about testosterone, which we will get into. But just thank you for being here. I'm excited.
Sure. I'm so happy to come on now because a few months ago, I actually went to the annual Menopause Society meeting, and this was one of the hottest topics there. And there were over 2,000 medical practitioners and nurse practitioners and everybody that's involved in taking care of perimenopausal and menopausal women. And it's so great that information that's correct is getting out to everyone involved in women's care.
Yeah. Amen. Amen to that. Well, as you know, we always start with the quick and dirty. It's our rapid fire segment. I know you probably better than other people in the world, but this is where we get to know our expert. Our listeners maybe don't, with bold questions, honest answers, and just enough spice. And we have a few questions before we get into the depth of the article. But the first one is, what is the number one thing that people should know about testosterone?
I think the number one thing is that they should be aware that, like anything else that you want to use in your treatment plan or in your body, there's going to be good and there's going to be bad things about it. And I wouldn't really take it to those extremes, like it's all good or it's all bad, but there's definitely benefits that some women can get from it. And there are risks that people should be informed about before deciding to start using something like that.
Good tease. I loved it. You edged us right to the edge. We're going to learn more about that in just a few seconds. But as you said, maybe women who are listening are like, I'm interested in learning more about my testosterone or what that, hormone does in my body. What are some signs that someone may have too high or too low of testosterone in their body? And what are some signs, or like, how do you educate people about if that's even something to worry about?
Well, what's really interesting is that somehow information got disseminated either through the internet or however people get their information, that if you as a woman have low interest in sex or low libido or low sex drive or any of those kind of problems, then it must be that your testosterone level is too low. And that over time, studying it and looking at the evidence and looking at actual studies at looking at women's testosterone levels, we know a lot of information about it now, and none of the evidence points to a cause and effect relationship like this person has low testosterone, therefore they will have a low sex drive, because it runs the gamut from women who may have low and their sex drive is perfectly fine, and women who may have high and their sex drive is low or perfectly fine. So you can't really equate the two, which is why so much of the information out there about women thinking they need to go into their doctor, they need to ask to have their testosterone level checked. And if their doctor doesn't check it for them, they're gaslighting them, because how would they know how much testosterone to give them? That's not the way it works. It really works to get to know your patient, ask all the right questions, find out if it seems that that person is having some kind of symptom or a diagnosis that might be helped by testosterone, and then possibly adding that into the mix of other things for their treatment plan. So we don't really assume somebody has too high testosterone unless we see them come in with certain signs and symptoms. And we see this sometimes in women who look what we call hyperandrogenized. And that means you may have a woman who has hair growth in places that women, let's say, don't normally grow hair. Like you may see it on the upper lip or on the back or in a male pattern on the abdomen or things like that. You may see acne and oily skin, a deep voice, periods that may skip many months because there's just not enough of the regular ovarian hormones, estrogen and progesterone, to produce a regular monthly period. So if you see signs and symptoms of hyperandrogenism, that would be a reason to test someone. But if otherwise, there's really not a lot of good reasons, unless someone's on testosterone, to start testing their levels to see if they're high or low. It usually has to do with symptoms.
That's really interesting. And so it depends. So I liked what you said originally around like the holistic look at somebody's health and medical history and seeing if testosterone is actually something that they should be, asked about. And then thinking about their symptoms and if it's something that feels like it's messing with their daily life, then maybe doing blood work and seeing what the testosterone level is. Is there like an average of like what it should be for a cis woman that's typical, or is that not really relevant?
Well, the range is so broad that since you're not really going to get a lot of information by randomly testing someone's testosterone level, we don't really test just to see a baseline. So let's say you have somebody that is on testosterone and you want to test their levels, which we can get into later on, about what should you be looking for to see if the testosterone is maybe in the right range to work for them. You want the number to be somewhere in the normal physiologic range for a premenopausal woman. So, there are ranges. We look for it to be up to maybe 60 nanograms per liter of blood, but it doesn't necessarily mean that if it's below that or a little bit above that, that it's indicating a problem. Mm-hmm. So the right way to go about deciding whether somebody may need testosterone is to listen to the patient. There are some very specific questionnaires that we use to find out if it sounds like this is a person who could benefit from testosterone.
Gotcha. And before we continue and get into the article, your specialty is menopause. And so one quick and dirty question we have is, what is one thing that women aren't usually told about menopause that they should know before they get there? Just one, if you had to pick. I know you're literally writing the book on it, but...
Just one thing about menopause that they're not usually told?
Yeah, that they should know before that they get there.
Wow, I'm going to be really specific then.
Great.
Because there are many very general things that no one is told. But, and this is another thing that is very big in the Menopause Society and on the internet right now. It's about vaginal health. So most women going into menopause, unless they've had the support of a menopause practitioner or they have a lot of good information, they're not aware that once they go into menopause and they don't have any more of their own natural estrogen, that the vaginal tissue is going to suffer. It's going to get drier. It's going to have less lubrication. There may be some pain. There may be some other discomfort associated with just being in menopause because the vagina and the surrounding area, the vulva, respond very much to estrogen. So many estrogen receptors there, so that if they don't do anything about that area, use estrogen, use something that's been recommended for them, that area will start to cause problems or become something that they have to deal with later on.
So figure out your estrogen supply in advance if you can.
Yeah.
Super important. Because pain during sex can ensue. Pain otherwise can ensue. And so it's really important to make sure your natural lubrication is available for sexual activities. Is that kind of the main thing that you hear from people who don't get enough estrogen prior to menopause?
It's not just for sexual activity. It's just purely for comfort and also for the bladder. There are tons of menopausal women who go through these cycles of urinary tract infections. They get one, they treat it, they get another one, and nobody ever says to them, what about using estrogen in that area to make sure that this doesn't continue to happen? And for many of them, once they start to use that, those UTIs, those chronic UTIs go away. So that's definitely something that menopausal women need to know about, and they don't necessarily know to seek that out from their practitioners. But now things are changing because vaginal estrogen products and discussions about it are all over the internet.
Yeah. So listen up, ladies. To prevent UTIs in menopause, pay attention to estrogen. Ask that question to your provider if estrogen might be right for you.
Just to mention, there are other conditions that kind of simulate menopause, and like women in their reproductive years who have been on birth control for many, many years, they may have the same problems with vaginal dryness. And one of the solutions for them also might be using vaginal estrogen. And that is a topic really poorly discussed. I mean, whoever says to somebody who's on a birth control pill complaining of dryness, oh, maybe you should use estrogen there. Sometimes people just go off the birth control pill, and that's worse.
Yeah, I can tell you first. I can tell you firsthand, I'm someone who went on the birth control pill and had a lot of vaginal dryness and pain during sex. And I wasn't offered estrogen from my gyno. But going off of the pill and just using a different form of birth control was just better for me. And that might be for you. And if you love your pill but hate vaginal dryness, then maybe estrogen could be a good benefit for you. Yeah. All right, we got to talk about this article now. So let me set the scene. I read the article when it first came out, and then I listened to it again before we're chatting for our interview today. It's called I'm on Fire. Testosterone is giving women their sex drive back and then some. Originally published at the end of October in 2025. It's written by Susan Dominus. And Susan Dominus has also written Women Have Been Misled About Menopause for the New York Times. And so just to set the scene, this article is all about women who are in their 30s, 40s, 50s, 60s, who are kind of rediscovering their sex drive by experiencing higher doses than typical women even naturally produce of testosterone through medical intervention, like pellets, which we'll talk about, other form patches, I'm assuming, creams, like other forms of getting testosterone into the body. And I guess just to start, like, what did you think about this article when you first read it, when you first heard about it? What were your first reactions?
Well, first, I have to say that a few years ago, Susan Dominus was one of the speakers at our Menopause Society meeting.
Go, girl.
For me, that was kind of like a fangirl situation because I had read the first article that you mentioned about menopause, and I thought, wow, she's really hitting it on the head. I mean, she had the cover of the New York Times Magazine, which is like, since when do they put menopause on there? So from there is kind of was the beginning. That was a few years ago of how people were becoming so interested in perimenopause and menopause and sexuality and all these things. And then at the end of last year, actually October, the article came out a few days before 2025's Menopause Society. So everyone was talking about it at the meeting. And we had a couple of really good speakers specifically on the topic of testosterone. So I had read the article right before walking into the meeting. And I thought that she provided a lot of good information for people if they read the whole thing, because there was a lot of stuff in there about women on very high doses of testosterone, like using these pellets and different ways to really bump up testosterone to levels that medically and scientifically we don't know are safe for women, because we do know that very high levels of testosterone can lead to things like liver problems and high cholesterol and some other things, because who has those high levels of testosterone? Men. And who has those problems with cardiac disease and high cholesterol and things like that? Older men. So if you're going to replicate the levels that men have, and those levels may produce a problem for them, even if you think you feel better, I think that's kind of a slippery slope to say, here's all these women who feel so great on these high levels. They want to have sex all the time. It's so great. You have to also look at the flip side. And she did that a little bit in the article by saying, that some women didn't feel well at all, and some women did experience some medical problems. So I thought it was pretty balanced as far as, like, if you read everything, you could come away from it going, I really need to go to somebody who knows about this stuff so I don't get the wrong doses or too high doses, and I can talk to somebody who knows about it. And then, of course, you see all these women or all these physicians and nurse practitioners, et cetera, come to a meeting like this. Now they're equipped, so they can be the people who women can go and discuss this with.
Yeah.
So I liked
Totally.
the article, though. I think anything that brings more awareness to this is very important. And she did discuss a little bit about how we make our diagnosis of someone who has what we call hypoactive sexual desire disorder, which for our societies is really the main reason to offer somebody testosterone. So there's a questionnaire, you ask people some questions, and if it seems like the question's responses would warrant something for libido, testosterone is one of those things that practitioners should know how to prescribe to offer it to them.
Do you know a few of those questions off the top of your head, just out of curiosity?
There are actually
I happen to know
I happen
them.
to have the survey right here. Well, I haven't memorized because I when I was seeing patients, I would off the top of my head kind of say, let's go through this 4-question survey just to see if it looks like this is something we want to discuss. So one is, do you feel like you're experiencing low desire? And 2 would be, was there a time that your desire was better? Like you can think back to years ago, maybe when you first got married or you first were in a relationship, you had a certain level of desire and now you've seen it noticeably go down. And then 3 is, do you want it to be better? Because, it's not for us to decide, let me tell you how you can get better libido if somebody is not actually coming and saying they want their desire to be better. And then the 4th question is it distressing to you that it's not as it used to be because you're feeling that it's going down? So this is disturbing you. And then you have to say kind of yes to all of those 4 questions. And then the last very big question is, do you think this lack of desire or this lowering of your desire has to do with, and then there's a whole bunch of things like relationship problems, pain syndromes, postpartum. Did you have surgery recently? Are there mental health issues? Is it a timing issue? Like there's so many things that if you say yes to that 5th question, then it makes sense to address that first. Because let me just go back for a second to the vaginal estrogen issue. There have been studies done where women who would come into their practitioners complaining of low libido, like I just don't want to have sex. Then when they question further about vaginal pain or vulvar dryness, et cetera, that was the issue. So that's not truly a low libido issue. That's a pain syndrome issue, a dryness issue. And if you can start using vaginal estrogen or something else, moisturizer, that takes that out of the equation, and then you feel like having sex again, that's not treating your low libido with testosterone. That's treating the root of the problem. And it's been found that in a lot of cases, there is something else going on. You had been mentioning to me when we spoke prior about in this article, the author discussed, what if somebody just really doesn't like their partner anymore or doesn't like the way they have sex with them?
Yeah.
That's not a let me offer you testosterone problem.
Right.
That's a address the issue with your partner problem, right?
We got to talk about that piece because, okay, first of all, everyone should read the article and then, if you didn't, and then come back and listen to this because there's so many pieces of this article that I want to get into. We'll back up, after we start talking about this and talk about like, what is testosterone and talk about the actual effects of it and that kind of thing. But we absolutely have to talk about this piece in the article because it made me laugh out loud when I read some of these quotes. And we'll get into kind of what testosterone does and the pros and cons of it. And we'll talk about, trans issues when it comes to testosterone and all of that. But I wanted to read these 2 quotes that I found hilarious and talk about kind of the cultural expectations around women when it comes to fixing, quote unquote, their libido. When the accountability is null when it comes to men. So one quote here says, one woman in her 50s told me, the author, that after years of revulsion at so much as the thought of her husband's breath, she now looked forward to having sex with him almost every night, right? Yikes. Doesn't really sound like a great relationship. One more quote that I want to share. This is from another woman, after years of wanting to, quote, rip someone's face off if her husband so much as touched her, she now actively pursued sex with him. Yikes. Okay. Yeah. So for me, and I want to get your thoughts on this after I rant, but For me, reading this made me so angry that the pitch is basically for women to use testosterone to fix their libido for being disgusted with their no good husbands. Like, that's it.
I don't think that is the norm. Like, that's not really what I was seeing in my office. Like, people would come in and go, tell me how to not hate him so much. It wasn't like that. But if the practitioner does the proper evaluation with these questions that I was talking about, like if you get to that fifth question and you say, do you think it's the relationship? If these women say yes, testosterone is not supposed to be their solution, right? I mean, it sounds kind of, I don't know, cliche, but one of the ways you kind of look into these questions would be kind of if everything were perfect in your relationship and you had no kids that were like knocking on your door and you didn't have to get up and go to work and you were on an island and everything was great and you were with this partner and he walked up to you, do you then want to have sex with him? If your answer is still no, testosterone is not going to fix that. Fix it. I always had this feeling that like when someone was coming in and wanting to discuss low libido and how we could quote unquote fix it with all of our things in our toolbox, that it should be a given that if there's something about the relationship, because who doesn't have something about the relationship that they might like fixed, it should be a given that part of the treatment plan should be some kind of communication therapy. Because I encounter this more than anything else when women are complaining about not being interested in having sex. How many times do they tell me, because I'm just too tired? Because you know what? He always does it the same way. And I don't have an orgasm at the end of it. Or it's just not exciting to me anymore. There are fixes for those things. And a lot of that involves communication. Like if you can train your partner on how to best pleasure you, then maybe you would be interested in doing it. But that takes work. And people think of testosterone or any other pill. Exactly.
It just makes me kind of sad, though. Like, I think that, to me, like, reading these quotes just about women being like, I'm repulsed by him, and now after testosterone, like, it literally feels like an SNL sketch. It just feels ridiculous.
I think she was really, not to, I can't know what was in her mind, but I really do think she was trying to show the gamut of, because she did discuss a lot of women who were like, I just wasn't interested anymore, and now I can't get enough. So that gives women the idea like, oh, that's the solution for me too, because I just want to take something and boom, I want the light to go on. Just like Viagra. I can, he can suddenly do it when he couldn't before. Now I want to suddenly do it. But women's libido is not located in one organ like a lot of men's.
And here's a plug also for our SMUT quiz, because I think that I think that we're taught as women, or we should be taught rather, that a lot of us have responsive desire, something that Dr. Emily Nagoski talks about a lot, and the fact that we need to get turned on by something. And so, in addition to communication, that we need to be talking about with our partners about what turns us on, we also need to know what turns us on in our minds. Like if we can get assigned SMUT passage, for example, by clicking the quiz link in the show notes, for instance, and get your like short passage that you can read to like turn yourself on, to get yourself in the mood. That is also part of education and communication, and around knowing what you like.
That means that women have to wrap their heads around the fact that responsive desire is still desire. And that is a lot of educating that has to go on there.
Exactly. Like, we want it. We just need something that sparks us into actually getting our bodies to catch up to our brains. Don't fast forward this. I'm going to tell you all about a SMUT quiz that we made. Are you having trouble getting in the mood? That's normal. Most of us don't start turned on. We get turned on by something. And that's called responsive desire. You just need a little spark to get you going. So me and my team made the SMUT quiz. You answer 5 quick questions, and we match you with your assigned SMUT, one single high heat scene from a book picked specifically for what turns you on. Not a whole novel, no slow burn. We drop you right into the good part. Read it in under 2 minutes and let your brain and body catch up. Go take the SMUT quiz now and get your required SMUT reading. Links in the show notes or at sexedwithdb.com. Let me tell you about the most fun homework assignment I have ever given: daily magic wand time. It started with me doing a 21-day experiment to answer one question. What happens to stress, sleep, mood, and sexual satisfaction when I use the magic wand every day versus when I have partnered sex versus when I have no sexual activity at all? The results were honestly so fascinating that we turned it into a full-blown scientific study with over 1,000 participants. Now we have real data on how consistent solo pleasure can impact mental health and overall wellness, not just orgasms. Curious? Go to magicwandstudy.com and read what we found. Welcome to the Lalo anatomy lesson you won't want to miss. Ever heard of the A spot, aka the female prostate? It's a deep erogenous zone located on the front wall of the vagina, about 2 inches deeper than the G spot. And that's exactly where Lalo's Enigma Double Sonic goes. It simultaneously stimulates your clit, G-spot, and A-spot using deep sonic tech that literally sends sound waves through your body. When folks ask me about blended stimulation, this is one I point to because it covers all 3 zones. Think a full symphony for the vulva. Want to get the toy loved by millions? Head to lelo.com now and use code SEXEDWITHDB for 15% off and give your A-spot the standing ovation it deserves. Moving on, though, back to this article, I want to know, from your point of view, let's back the truck up. Like, we went over this in our last episode that we did together about hormones, but for the context of this article, what's important for us to know about testosterone, what it does, how does it do it? What are some, myths that you want to dispel about testosterone? Let's get a baseline education and understanding about it before we delve into what people are doing with it.
I think the facts are important. One misconception is that people think that at menopause, suddenly your testosterone level starts to go down just like your other hormones tend to go down, and that's an untruth. Testosterone is a hormone that in women is made about 50% in the ovaries and 50% in the adrenal glands, which is kind of why there's no sudden drop when the ovaries are not working anymore, because it's made in other places. However, peak testosterone in women actually happens way earlier than people thought. And it's really somewhere in the 30s or so that you peak, and then it starts to go down. Kind of just like the idea of like fertility after 35 and ovarian function is less. So your testosterone starts going down and continues to go down. And there's no sudden drop at menopause where it just goes to nothing. It doesn't happen. And then throughout menopause, it's actually pretty stable. So that's very hard for women to suddenly say at age 60, it must be my low testosterone that's causing my lack of interest right now, because it's not. Medically, numbers wise, it's not that. We do know something very recent is that later on, maybe in the late 60s or early 70s, there seems to be a small bump in testosterone that women get, and nobody really knows why. But they also know that suddenly women don't become interested in sex at that age also. So again, another proof that
piece of evidence that it's not all testosterone.
Exactly, that it's not all about like your level equals your desire. I mean, women's desire is a very complicated thing, testosterone being part of it, because the way they started to think, maybe we should give testosterone to women who have low libido or low desire, is that they checked testosterone levels in many different women in many different circumstances. And it seemed to show that women with high natural levels of testosterone seemed to have more interest in sex, more libido, more drive. So they came to the conclusion from those numbers, hey, maybe if we give women testosterone, their drive will go up. But it seems that women with higher levels have better drive, but not to the point where it's a one-to-one, like if I give you testosterone, your drive will be better.
Right.
It's actually a work in progress. Like you have to do the work, like do the survey, ask the questions. If it seems like someone might benefit from testosterone, you start them at a level that is about 1/10 of the level of men's testosterone replacement, which, that brings us to the idea of how are women supposed to get their testosterone, right? if you really want to go with what the evidence shows and what the Menopause Society shows and what testosterone scientists say, it seems that a tenth of a dose that's made for men would be the dose to bring women's testosterone levels back to a normal reproductive age women's testosterone level. And that seems to go along with better libido. Now, we were mentioning before, so then how do you get it into your body? If you're going to use the evidence and the guidelines, mostly women practitioners are doing prescriptions for male products and then having to explain to women that they use a tenth of a packet of something, or they use a tenth of a squirt of gel or something like that. It's kind of difficult, but it's doable. The other way is that, compounding pharmacies can make it, but according to many societies, they worry about that, about the purity, about how much are you really getting? Is anybody really watching how much they're putting in those compounds? I mean, me personally, I think if you find a good compounding pharmacy as a physician and you work with them and you trust them, there's a way to get testosterone from there as well. And then the last way is unregulated, like people on the internet.
Med spa.
Yes, med spas and places like this, which have no regulation, no oversight, may or may not test your levels. But I've had women come into my office who have been on these unregulated ways to get their testosterone. And while we're looking for up to maybe a 60 or a 70 to say, okay, we know up to there is safe, I've had people come in with 1,300 level of testosterone, 1,500, 3,000. And, some of them don't really care. As in this article, she did talk to people who, knew that you could get a deepening of the voice, which is irreversible, knew that they could grow hair someplace that they didn't want to. I mean, that's all like a risk-benefit ratio. And the problem is women who want to take testosterone really have to be well-informed about what the science shows, what the possible side effects are, and what they can expect from it. Yeah. And then somebody has to follow them closely. They can't just give them testosterone and say, don't come back.
The med spas do. The med spas do. Okay, this is interesting though, because, spoiler alert for the end of the article, right? Like there is one specific woman who did get hair, places she didn't want to. There's another woman who lost her hair on her head because that is something that testosterone can do. And she was asked at the end, your hair, she mentioned my hair grew back. Would I do this again? Absolutely. I would do it again. Right. So it's interesting.
Everybody has a different level of, risk. Acceptance.
And a lot of women in this article, they report having more energy, more focus, less emotional intensity. And there's also, of course, a focus on libido and sexual pleasure. One source said she was having orgasms for the first time in years. Another source said she orgasmed for the first time ever, I believe. Or, basically just saying that their orgasms were infinitely better after they started taking testosterone. Talk to us about the science of like how this happens. Why is greater testosterone potentially linked to better or more orgasms?
That's a big question. The best testosterone scientist that's out there is a woman in Australia, Dr. Susan Davis. She came and spoke at the Menopause Society, and she is the person who has done a lot of the research on mostly post-menopausal women, although I think they're recruiting now for peri and pre-menopausal women to test how testosterone affects their level of function, their sex drive, their quality of life. And she presented at the Menopause Society all the data that they have. And unfortunately, at the end of her talk, basically, it's like there's just so much that we don't know that we have to do more studies on it. But basically, they're not really sure if testosterone does one of several things. One is it can affect your brain function, right? Because testosterone is very strongly tied to several of your neurotransmitters, like dopamine, et cetera. And those are your pleasure-seeking neurotransmitters. So if it's connected and your higher testosterone levels might affect dopamine, that may be one way that it can affect sex drive. Also, in the body, testosterone is somewhat converted to estrogen. So there are theories that maybe it's the bump in estrogen that people are getting.
Converted to estrogen.
Right, somewhat converted. Like
In
there's a
what way?
process called aromatase, or aromatization. And not all of it, but some testosterone converts. So maybe it's that, Also, testosterone might affect the estrogen receptors. Like there are products that are topical testosterone that are made for the genital area. And it's usually a mix of things where they use testosterone and Viagra, believe it or not, in a cream form where women apply that. But again, as they presented it at the meeting, the instructions are take this cream, apply it to the genital and clitoral area for 10 minutes and rub it in. See if your interest improves. I mean,
Sure.
Take any cream, so there's so much they don't know about exactly whether it's the effect of the medication. And not only that, medications that are designed to improve your quality of life in the studies have a very big placebo effect. Like whether the person knows they're actually using the medication or not, many women who apply something and then are asked, is your quality of life better? Is your sex drive or your sex interest better? Many of them say yes, and they may be on a placebo product, So it's difficult to know. But we also do know that for these women who report things like better energy or lower joint pains and things like that, that's all anecdotal. They say it and we see it in general practice. I definitely have seen it, but I don't have enough evidence to say those joint pains you're having, take this testosterone and that will be better. It's just part of an overall feeling of well-being. But again, in order to make it appropriate to prescribe for women in general, you have to have the studies. You don't want to be prescribing things that are potentially harmful when you don't have evidence for what that harm might be.
Yeah. I mean, I think something that I learned in the article that I'm curious to get your take on, speaking of the studies, is that the FDA has approved more than 30 products since the 1950s when it comes to testosterone. And yet to this day, there is no FDA-approved testosterone cream, patch, pill, or shot for women, even though their testosterone levels fall far more precipitously than men's as they age, even though we heard you in the beginning of this episode, and we were talking about the fact that there's not as precipitous as a drop as one might think, still higher than men. Can you tell us why, other than sexism, what is going on here? Why is there so many products that are approved for men and not for women?
Well, that's the story of misogyny, but that's for another, episode.
All right, great.
So I can tell you they did get fairly close to approval several years ago with a product that was a testosterone patch for women. They evaluated it, they did the studies, it seemed to provide the desired outcome, which was an increase in sexual desire and libido. And it got all the way to the top tier of the FDA for approval. And they rejected it, saying, we need more studies.
Classic. So it got all the way to the top, then it got denied because we need more studies. How are we supposed to get more studies if we don't get more studies? What are we doing here?
I think that kind of put the kibosh on it. And the fact that there is an available product now in like Australia and the UK and South Africa and New Zealand, much more progressive with their studies and much more interested in, women's libido, I guess. But the United States, I don't think is going to get close now.
Okay, so it is available in other countries at the doses that are seen to be quote unquote safe for people who want to improve their libido, but it's not available in the US. Another thing that I kind of want to talk about here, switching gears, is specific to trans health, because right now we kind of talked about this a little bit throughout the episode. Testosterone is a highly regulated substance by the FDA. It's currently only approved by the FDA for low testosterone cis men, for low testosterone in cis men. But on December 10th, 2025, the FDA did host a panel advocating for looser restrictions, but again, only applying to cis men. And a question that I feel like I wanted to talk about, even though understanding like this is not your expertise, I just think it's important for it to be said. when talking about trans men, right? Like trans men are only really mentioned twice in passing in this piece. Trans men, as listeners may or may not know, if they are receiving gender affirming care and if they decide to use medication for that care, testosterone can and is a part of that care sometimes. And in much, much higher doses, of course, because we're talking about having, your body matching your gender identity of yourself in your head. And that can, include a deeper voice, facial hair, more muscle mass, et cetera. And testosterone can help with those things. But in this New York Times article, trans people who are listening, they might agree that the New York Times can and has been aggressively anti-trans when it comes to not supporting trans voices and trans healthcare. And many trans folks online saw this piece as a bit of a slap in the face, considering how extremely difficult it is for trans people to access hormone therapy. But when it's for cis women, it's like, great, go girl, get your libido back. But when it's for trans men, it's a lot harder, and it's not in the zeitgeist as like a fun thing that trans men can easily access. So I'm curious, from your experience of working with trans patients and doing research and being in this field for so long, what do you think that trans people should know about testosterone, and specifically trans men? And what's your kind of feeling specifically around like the comparative ease of access that cis women kind of potentially can have with these med spas and other ways of it being in the zeitgeist compared to trans men?
Well, I think looking at where they might get the testosterone from is really important, because in the same way that women accessing testosterone from places that are not really medical professionals giving them doses that may not be the recommended dose, if trans men go on testosterone, which that should be a part of gender affirming care, because that's the only way to create male sexual characteristics, like, as you described, facial hair and more muscle mass, et cetera. So I do think that the things that have to be looked into or evaluated when women go on testosterone, which is they have to check their levels, they have to check their cholesterol, they should check their liver functions and things like that. If the FDA or whoever says women should not have available testosterone because you have to check all these things, then men or trans men who are getting much higher doses of testosterone, supposedly safely in a gender affirming environment, should also have those things checked. So I think it just goes both ways. That like,
what's the problem here?
Yeah, exactly. So, I mean, it's been established that there are protocols for how much testosterone trans men should be administered to maintain those desired sexual characteristics or male characteristics, as long as they do it in a safe way. So yes, they're going to get a deeper voice. That's a desired side effect for that situation. So if women do not want that side effect, the same kind of testing needs to go on. But I don't think they should say, well, women are too much at risk with all these things that could happen to them with a 10th of the dose that a man would be on, so we don't want to make it available to women. I mean, it makes it hard for anybody to get it, especially that, I don't know if you even know this, but testosterone is considered a controlled substance in one of these schedules, just like opioids or, medications that really have to be monitored. So if you prescribe testosterone, it goes to the data bank, and, you're being watched for your DEA license.
Didn't you have a story that you wanted to share about this?
Oh boy, yeah. When you prescribe controlled substances, they're in all different schedules and all different categories. And the DEA takes note of prescribers who are doing a lot of prescribing of controlled substances, and they may not look at the overall specific types of medications you're prescribing. So when I was practicing in New York in a private practice, I had just actually started learning how to do hormone prescriptions, and women were interested in testosterone. So I got educated. I started doing these compounded prescriptions. So, in that situation, you write a few, they tell their friends and they tell their friends, and lots of people start coming in. And for me, it was a learning experience. And also it was great to be able to see the effects on all these women. They were very happy and we were doing it safely, but I was writing a lot of prescriptions. And one day comes knocking at our office reception area. The DEA comes with, badges and those vests on the back. It says DEA.
Freeze, too much testosterone.
Exactly. Came to my front desk asking for me because they wanted to investigate someone who was prescribing a lot of controlled substances. So, I don't even think they had the list of what I was prescribing, but they knew it was a lot. And they came in almost like they were going to, I don't know, break down the doors or something like that. And they scared my receptionists. And when I sat down with them, I was like, this is what I'm prescribing. This is menopausal women with low libido on all this testosterone. And I think I either embarrassed them or, maybe they didn't know what that meant, low libido, or maybe they did. They left, pretty quickly. But, if somebody's watching how you prescribe and what you prescribe, and there's all these rules and it's not FDA approved, and it makes it once again difficult for women to get what they need for something that really is a medical condition that's a quality of life issue.
Wow. So crazy picturing you being like, I'm just prescribing testosterone, officer.
Not only that, I did end up saying, do you want to be the one to tell all these women that you're going to take their testosterone away? Have at it.
That's really funny.
Imagine the stampede.
Oh my God. I mean, it's interesting when did that happen? Like 20 plus years ago?
Yeah. When was I in that office? Started in probably in the early 2000s.
Yeah. So I feel like it's kind of interesting that we haven't really made much progress. There's still not something that's approved for women. Obviously, gender affirming care is not easy in many states for trans people to access. And cis women are still having communication issues with their partners and are kind of using testosterone as a way to want sex when maybe there are a lot of other issues at play.
Well, not only have we not made progress, it also feels like this has been a way that influencers and people without much knowledge see a little niche where, everybody's talking about this now, everybody wants this now, and providing a way to unsafely get it to people, because most people don't know the difference between getting it from someone online who says, oh, look, everyone's talking about testosterone, it's safe now, I can provide it for you, versus somebody who just went to the Menopause Society meeting and listened to all the details and the science and the evidence. You have to see where your information is coming from so that you're not harmed.
Yeah. So speaking of that, we're at the end of our interview here, but because you're such an expert, are there places that you recommend people do go to learn more about testosterone? What kinds of questions should they ask their doctor if they feel like, you went through that quiz and they're like, yeah, that actually is me. I might have low libido and I'm interested in potentially pursuing testosterone. How do you recommend people go about this in a safe, educated way?
So I do think that they have to have in their minds that testosterone is not the only thing out there that might be able to help them, because I think it's not really good for a patient to walk into their practitioner's office and say, this is what I want, and I want you to give it to me, because that's not the way evidence-based medicine should work. You should be able to work with a practitioner that has what I always refer to as the toolbox. They do their interviewing, they do their history, they do their exams, they may do some blood work here or there. And then they say, okay, based on everything we've already discussed and based on the safety issues, because there are some people that are not candidates for any of these things, here are the different things that might help you with low libido. And I usually would have a handout or something that they can go home and kind of mull over all the different possibilities. But there are 2 FDA-approved medications for premenopausal women with low libido. One is a pill, one is an injection. As a matter of fact, a really interesting new documentary just came out called The Pink Pill: Sex, Drugs, and Who Has the Control. It came out at the New York Documentary Festival recently.
Is this about Addie?
It's about Addie. And I think practitioners should make that available to women who qualify for that. There's also, like I said, an injectable medication that many practitioners are not familiar with, don't know about, and are not familiar with prescribing. I think they should get educated about that. There are other medications that are in the toolbox that might help low libido, and some of them are, antidepressants, anti-anxiety medications that have a side effect of helping libido. But again, testosterone is definitely in that toolbox, and women who might be interested in having a discussion about low libido and going over all the different things that are out there should seek out someone who is menopause certified or menopause trained if they're menopausal, or if they are premenopausal, if they're reproductive age, this affects them as well. They should ask before making an appointment, is this a practitioner who's familiar with guidelines for sexual health as far as low libido? They can, say it specifically before they make an appointment for low libido. There are societies that they can go on their websites, like the Menopause Society, if it's an older person, or the International Society for Sexual Health in Women, another place where you could get various practitioner names who may work in your neighborhood. And then there's several telemedicine companies that do this kind of work as well. And when you're looking up a telemedicine company, you want to look and see if they deal with low libido, because now if they want to, keep their clientele and make sure that they're serving women in the best way they know how, people like at this meeting that I went to where so many people attended, they're getting that information. So they should be able to, spew that out to their clients and their patients.
Spew away. I love that verb. I love that. That's all really, really helpful. As always, you are a fountain of knowledge. And if you're listening and you're one of those people who's repulsed by your husband, maybe get a new husband, and maybe then you might not have such low libido. No, I say that in jest, but I do want to recommend that people who read the article, and if you can see yourself in there as someone who is absolutely not interested in the thought of being touched by your husband, that you think about what that means, and that you don't take a pill to fix something, and that you do some investigating.
There also is just one podcast I would also like to recommend. There's a podcast by 2 OBGYNs who are very up on all the material. I saw them at the meeting, and the podcast is called Ovary Active.
Oh, nice.
And it's specifically about perimenopause. But, as we know now, perimenopause spans a very wide age range, starting sometimes in the 30s and going all the way up to when someone goes into menopause in their 50s. So there's a lot of women who could get information from a perimenopause podcast. And I think they have very specific episodes on testosterone, on libido, on all the things that you and I have discussed.
Love it. Thank you so much for being on and for sharing all of your wisdom and knowledge. I love you so much.
Thank you. I love you too.
And welcome to the Afterglow, where we wind things down, reflect on the big takeaways, and leave you with one juicy thing to try, think about, or explore before next week. This article was a wild read, and it's always good to check in specifically with my mom and her expertise about women's health when it comes to topics like these. It's exhausting to navigate the waters of medical misogyny, especially when we can clearly see that something might be beneficial for women if we would just devote money to research. And this isn't something we're likely to see change without governmental urging and intervention. On December 10th, 2025, the FDA did host a panel advocating for looser restrictions on testosterone, but again, this was only applied to cis men. Even then, it seems like getting this panel to happen in the first place was an uphill battle. If listening to this episode made you interested in testosterone, make sure you talk to your medical care team about the risks and benefits according to your own health and body. Every single person is different, and the only people who will know if it's a good fit for you are you and your doctors. Have you tried testosterone to help with your menopause symptoms? Have you tried it for any other wellness reasons? Are you a trans person who feels relieved to see a push for wider access to testosterone? Or maybe frustrated that cis women are getting access to the hormones you need so much easier? We would love to hear from you as always. We really do read all of our emails, so please email me at sexedwithdb@gmail.com. This is such a nuanced conversation that I'm excited to talk to you all about and learn from when it comes to your experiences. So here is your pleasure practice of the week. This week, check in with your body. It's simple but important. How are you feeling right now? Have you been low energy lately? Have you been feeling less desire or pleasure than usual? Have you been sleeping right? Next, check in with your environment and your external factors in your life. Have you been especially stressed, or has your mental health not been great? Mental health is health, and that means it can and usually does impact your body. But make sure you're checking in on your physical health too. When was the last time that you had a regular checkup with your doctor? Do you go to your annual appointments? And if not, make sure you get one on the calendar for 2026. And don't forget, sexual health impacts your physical and mental health too. If you haven't read my study on masturbation with the magic wand to see just how important pleasure is to your day-to-day quality of life, the link is in the show notes. Thank you so much for listening. Talk to you next week. Love y'all.